Yeah, good evening, everyone. Today, for our scientific webinar, what we have started during our COVID times, we are continuing every Tuesday. So today we have an interesting topic, really the booster dose is required in COVID or not. I believe almost 100% of the healthcare workers and doctors have been vaccinated. Now, including me, our antibody levels are being winding up. My antibody levels are negative now. So there is a big question among doctors and among all healthcare workers or even people also that they should go ahead and take that booster dose or not. There are some positives and negatives about booster dose. So today we have Dr. Naresh who is going to talk on evidences right now in favor or against the booster dose. And we have Dr. M.B. Rao. He is one of the senior most physician here with Yashoda Hospital, Somajigoda. He has vast experience in every field in medicine. Apart from that, he has treated, I think, thousands of patients who are COVID and lot of patients who are being vaccinated. I think he's the right person to be here with us to tell us about the role of booster dose in COVID right now, which is really a mystery and puzzling every one of us. To go ahead today, so I will request Dr. Naresh to start his presentation, to try to unsolve the puzzle what we have with us right now. Thank you.
Yes. Sir, very good evening to all the senior members of the faculty, M.B. Rao sir and Dr. Mishra sir, and dear colleagues and dear students. The last few weeks have thrown us into a need for analyzing the effect of the booster vaccines and how they work over time. And this is done in view of the anticipated waning of immunity. So today we will be addressing the issue of vaccine booster from the evidence point of view. COVID has changed our perspective to a great and inconceivable degree. And what we previously thought was very much not going to be the way it was. We have been fighting it back from the hospital point of view, but that is not the war, where the war is. The war is at the community end, and we have to fight it at that end. So when we look at how effective the vaccines are, when I wanted to take one country as a model and which followed all the WHO guidelines, including lockdown and vaccination, and then extrapolate it to the rest of the world. So the country which had good amount of data was Israel. So Israel had already faced the first wave of COVID, and the second wave of COVID initially started off at around the first week of December, and it peaked at around the middle to the end of January. And they started vaccination for healthcare workers at the middle of December, and for the general population when they began at January. And by May end, they were able to reach up to 60% for dual dose, 2 doses, and 55% for 2 doses for single dose. And the graph correlates to show that the graph above, which is orange in color, this shows the weekly hospital admissions per million. And the yellow graph shows the weekly ICU admissions. Here we see there is a lot of correlation between the amount of vaccines that have been given to the population and the hospitalization as well as ICU admission of the population. So when we come into vaccines generally, not just COVID, we have a variety of mechanisms which include RNA vaccines, DNA vaccines, recombinant protein vaccines, live attenuated, inactivated, and viral vector. When we come into the COVID vaccines, the vaccines which have data and which do support any form of evidence right now are only these few vaccines. Out of them, I have color-coded them. Pfizer and Moderna are mRNA-mediated vaccines. Oxford, AstraZeneca, and Johnson & Johnson are viral vector-mediated. Both of them adenovirus mediated. Covaxin, Sinovac, and Sinopharm, these 3 vaccines are inactivated vaccines. We don't yet have any DNA vaccines or other forms of vaccines. So when we come to the efficiency of vaccines, we should understand how well the vaccines are working. So this is a study which is ahead of print. I could not get the reference for it, but I had included a DIO in that. This is yet to be published. And this was accepted for publishing on August 29th of 2021. So here they have compared from the first from the January and up till June end. They have found in different age groups and the amount of incidence rate per 100 population of hospitalizations. In that, they found that the people who are unvaccinated had a huge degree of increase in the number of hospital admissions. In the age 18 to 49 years, it was 23 times more, and 50 to 64 years, it was 22 times higher, and even above 65 years, it was 13 times higher. This clearly shows how effective the vaccines are in preventing a hospital admission. Infections may not be prevented, but mild form of infections which can be managed out of the hospitals definitely are being benefited by the vaccine. That was the population of the general population. But in US, they have gone ahead and they have done this study in the population of healthcare workers. Here, in the US, the vaccination started on 11th of December. And these people have started this effectiveness among healthcare personnel study team have started the study on 20th of December, and they have followed it up to the 19th of May. And they have taken 25 states and 500,000 participants. Out of them, they did a case control study. They have defined cases. They have defined cases as a PCR positive or antigen-based test positive, and at least one of the COVID-19 symptoms which they included. And controls were defined as on the basis of a negative PCR or regardless of symptoms, and were matched. The cases and controls were matched, and they were followed up. The study included around 1,482 participants in the cases and 3,449 control patients. And they have classified it as, and they have administered vaccines to them. Most of the patients in the cases and controls both almost equally received the Pfizer BioNTech and Moderna as 20%. Johnson & Johnson and AstraZeneca, only 1% of the study group received those vaccines. So Pfizer and Moderna, both mRNA vaccines, these were the predominant vaccine, needing 99% of vaccines that were delivered to both the cases as well as the controls. Now, they have defined a partial vaccination and a complete vaccination. By partial vaccination, they meant that they viewed assess the patient from 14 days of the receipt of the first dose and up to the 6th day of the receipt of the second dose. And complete vaccination was assessed 7 days after the receipt of the second dose. And in these populations, they tried to see what was the vaccine effectiveness. They found that after partial vaccination with Pfizer, 70.9% effectiveness was attained, and complete vaccination, it was 88.8%. And Moderna, it was 88.9% with partial vaccination and 96.3% with the complete vaccination. Overall, it was a 77.6% effectiveness of partial vaccination group, and the complete vaccination group had 92% effectiveness. They went ahead and after analysis, they have understood that both the mRNA vaccines were highly effective under real world conditions in preventing COVID-19 in the healthcare personnel. We should remember that this study was run in the high risk population who were being exposed on a daily basis, and in them the effectiveness found to be very good. And in the late submission to Gavi Global Alliance of Vaccines, both Pfizer BioNTech as well as Moderna have claimed that after 6 months, their vaccine effectiveness was reaching 91.3% and 94% respectively. But these studies, both these studies, they had followed up the patients only for 15 weeks. Later on, other studies have been published. This study, they have followed up BioNTech, only Pfizer BioNTech vaccine through 6 months. And then they have tried to analyze. So first vaccine shows the efficacy of the vaccine, the effectiveness of the vaccine. And this article, I wanted to concentrate on the safety of the vaccine. When we look at the effectiveness of the vaccine in this study in the general population up to 6 months, we see the difference between the placebo as well as the BNT group was huge. And when we look at the risk of population, first occurrence of in the partially vaccinated group, the at-risk population number of cases was 77. And they have matched the cases and the placebo, 77 in the number of cases in the vaccinated group and 850 for the same amount of population in the unvaccinated group. And also after that, they have documented first occurrence after the receipt of second doses, 81% of the cases among 21,000 population. And here in the placebo group, it was 873 population with at a risk of around 21,000 population. So we see a huge number of difference. They have tried to match 20,712 and 20,713, and also 21,600 and 20,600. The amount of people, the amount of cases where they had positive detected, the variation is very huge. So here they concluded that through 6 months of follow-up and despite a gradual decline in vaccine efficiency, it had a favorable safety profile and are highly efficacious in preventing COVID-19. Here I wanted to concentrate on the 6 months follow-up period. So as of now, we should have understood that the data what we have is most of them related to mRNA vaccine, both Pfizer as well as Moderna, with faint hints of data from Oxford, AstraZeneca, and almost no data from Sputnik and the other vaccines. Coming to the core issue, are booster doses of COVID-19 vaccines really needed? And if they are needed, are they meant for the general population or for the high-risk groups? And what is the optimal timing for a booster dose to be given? And can there be mixed doses which can be given, or the homologous vaccine, the same vaccine has to be given? So first we should understand is that this is not a hospital problem, it is a public health problem. And as of now, what it appears, the government have come to an understanding, everybody has come to an understanding that vaccine appears to be the only solution. Previously, we wanted to look at herd immunity, but when we look at data from Israel, what we understand is that herd immunity has not yet been achieved. And most of it is related to the new Delta variants. I'll be explaining the Israel model in the subsequent slides. So after that, we have, when we come into the area of domain of booster vaccines, then we have to understand how long will the vaccine be effective. And even after the first dose, how long will the vaccine be effective? And how severe are the vaccination, how severe are the infection the vaccinated individuals as compared to the non-vaccinated ones? And what is the chance of reinfection? Is reinfection a cause of concern? And what about the new variants? So as per the data available and as per submission by submission to Gavi by both Pfizer and Moderna, they say that at 6 months also there is sufficient amount of effectiveness. And coming to the severity of the vaccine, definitely vaccines have shown that the severity of the illness, incidence of ICU admissions, the incidence of hospital admissions as well have come down significantly. The chance of reinfection, as of now, the whole chance of reinfection throughout the world is estimated to be around 0.7%. And reinfection is definitely a cause of concern when the initial infection was very severe with landing up in the ICU. And such patients who recover and go out and come back with a reinfection tend to have more severe infections. So what happened in Israel? This was the previous slide. So initially they had started vaccination at December, January, and by May they had come to up to 60% of vaccination cover. And also gradually the wave come down, and by the end of May they had zero amount of cases. This was ICU admissions as well as hospital admissions, and even the deaths were come down. So it was the vaccination initially at that point of time showed so much effectiveness. At one point of time, the new cases were in double digits for a few weeks in Israel. But later on, when a few weeks later, the peak started again rising despite the vaccination. And initially it was thought that it was only the unvaccinated population which was getting into the hospital and becoming sicker. But later on, it was found that those who received 2 doses as well were also getting sick, and the number was also correlating. The graphs were also very near. At this point of time, with the new government in place in Israel, they have gone ahead and they have approved a 3rd dose booster for over the age of 60 years, and they have started it. Then it comes to concern, what is a booster dose? Why should it be given, and for whom it should be given, and when it should be given, and in where, in the sense geographical area. So booster dose, a vaccine dose which is given after the primary series that are needed to increase the immunity after waning of the after waning of the initial immune response is considered as a booster dose. Why a booster dose? Booster doses are logically explained by waning immunity, the vaccine effectiveness with time, the newer variants, the daily exposure of the population as well as high-risk groups, the immune compromised nature of the population, the frontline workers, and finally the country economics. Different vaccines have different vaccines have different responses at different point of time. When we look at these 4 graphs, A, B, C, and D, graph A shows that the initial response was above the protective titer, but it was not high, but it plateaued soon enough. Graph B shows that the initial response was high and it plateaued. Graph C, initial response was huge, but the titer subsequently went down to below the protective titer. And graph D, the protective titer was not even reached. At this point of time, at graph for the vaccine for the condition D, if a vaccine was provided at this point of time, they might have been an additional booster which would push the antibody titers to a higher level. And the same for C graph. What the booster doses are meant for, they are meant to reaffirm the waning immunity by means of re-triggering the immune response to a repeated stimulus. So why 2 doses? When we consider the initial infection as well as the vaccine first dose, there is a primary response, but gradually it wanes. And after that, any subsequent infection or any subsequent vaccine the secondary immune response is stronger and it is more bound to have immune memory cells, B and T cells. So when we come to this, who is the people who are likely to benefit from such a event, such a intervention? The first thing which comes to mind is people who have daily exposure, which include the medical personnel, other frontline staff, the immunocompromised patients, as well as the elderly patients. Why are they likely to benefit? The first thing is that the risks are very minimal because already they have received vaccines and most of them do not have, and vaccines appears to be safe. And the benefit is huge in terms of preventing hospitalization and maintaining essential services. However, national economics is also an important point because many countries have gone into lockdowns and have suffered economically. When is to consider a booster dose? As of April, according to the submission to Gavi, they thought that at 6 months also, their submission stated that 91.3% of Pfizer as well as 94% effectiveness of Moderna vaccines. So it was logical to conclude that the vaccine booster dose, whatever had to be given after 6 months. So this is a data which I could gather from the Indian context. Here, this was study done by ICMR in their Bhubaneswar Institute. What they did was they took 614 patients and out of them they divided into 308 patients who received Covishield vaccine and 306 patients who received Covaxin. Out of these 614 patients, 81 patients got infected with COVID-19 vaccine for the first time. And among the 215 patients in the same group who already had previous infection, 33 people had a reinfection. And the surprising thing was that antibody level of those who got Covaxin started to decrease significantly at 4 months, and for Covishield vaccine, it started to gain significantly at 6 months after the initial first start. The statements by both of them, by the author, was that in Covaxin antibodies started declining in the 2nd month of vaccination. In Covishield, antibodies started declining after the 4th month of vaccination. But however, they add that this does not mean that the person is fully protected. TN is not fully protected. T and B cells are also a factor which help in creating the memory to fight the virus. I could not get the PDF of this study and unfortunately I had to pick this up from the press. Then when we come to the Israel model, the evidence after starting a booster dose, they have published an article on September 15th. They followed up the patients who had received vaccine. So the selection criteria was any patients over the age of 60 who already received the vaccine 2 doses 5 months prior. They were eligible for receiving the 3rd dose of the vaccine, which was supposed to be a booster dose. And they were following it up with the severity of the illness and the rate of hospital admissions. Here, when we look at that in the non-booster group and the booster group, the number of cases in the non-booster group for the population were 4,400. In the booster group, it was 934. Number of cases, and number of cases for severe illness, the number of cases was 294 in the non-booster group and 29 in the booster group, and they have included the number of person day at risk. In conclusion, they found that the study involving who were 60 years of older who had received 2 doses of BNT and followed by 5 months later receiving another dose, the severity of the illness was substantially lower among those who received a booster dose of the vaccine. But we should understand this study because they had followed up the patients only for 12 days and not followed up the patients later on. The amount of vaccine effectiveness was to be assessed later on, but this article was probably they'll be republishing this article after the few weeks more. So where should the vaccines be administered in the geographical areas? First, we should understand that the vaccine stocks are very limited and 75% of the population is yet to be receive a single vaccine shot. And it wouldn't be wise at this point of time to deny the single vaccine shot over the booster dose. And low-income countries are still grappling for vaccines and aren't getting much help and are and can form a breeding grounds for further variants development. When we come into India, Indian vaccination began on the 16th of January. And they started with the medical professionals and allied professionals and healthcare primary exposure groups. And as of yesterday, 91 crore vaccines were given in India, of which 18% of the population has been given 2 doses and 47% of the population has been given only 1 dose, I get. And there needs to be a justification of who gets the booster vaccine when our population is near 140 crores and 91 crore vaccines have been given, and yet we have not achieved even 50% of the vaccination for two doses. There needs to be a justification of who gets the vaccine, and it would be rational to say that the high risk groups should be preferred over the general population. After the evidence from Israel, CDC also had gone ahead and issued a statement that they recommended a booster dose at 6 months for people over the age of 65 years and residents of long-term care facilities, and patients and people aged 18 to 64 years with an underlying medical conditions, as well as people who are occupational or have an occupational or an institutional setting exposure. When it comes to the booster doses, now we are coming to another area, which is giving the same dose or giving the same vaccine or giving a different vaccine. So giving the same vaccine is called as homologous vaccine, and a different vaccine is termed as heterologous vaccine. In the homologous vaccine, the same vaccine is repeated, and it is supposed to boost the same mechanism, and the side effects are expected to be nil, but the results are expected to be a reinforcement. But when you come to heterologous vaccine, when we are giving a different vaccine, the expected mechanism is not yet clear. The side effect profile has to be reassessed, and the results can't be theoretically predicted. And there are studies which showed the heterologous vaccine administration. This was a review article published. So what they have done is they have seen all the vaccine combinations. So when they have they have seen that no vaccine booster was given, Chad is Oxford AstraZeneca, BNT is Pfizer BioNTech. They have grouped the participants into 6 groups. The first group was receiving only Oxford AstraZeneca. The second group received Pfizer. The third group, where they received a booster dose of AstraZeneca after the regular 2 doses. And the fourth group included 2 doses of Pfizer BioNTech followed by another dose of Pfizer BioNTech. And the fourth and the fifth group are the heterologous groups. Here, the fifth group received Oxford AstraZeneca, followed 6 months later by Pfizer BioNTech, and vice versa in the 6th group. When we get into how these reactogenicity and the vaccine effect was there, when we see the neutralizing antibodies, the highest amount of vaccine neutralizing antibodies were found when there is heterologous group. They have noted the amount of stars, the more the stars, the more the effectiveness. And they have shown that the maximal efficiency, maximal immunogenicity of neutralizing antibodies was found with booster vaccine, with the heterologous vaccine from booster Oxford followed by Pfizer. And the binding antibodies were similar as well. T cell responses were the best with the same Oxford followed by Pfizer. And coming to the reactogenicity, coming to the immunogenicity against the Delta variant, the best immunogenicity against the Delta variant was found with Oxford followed by Pfizer. However, we should understand these things that both Pfizer and Moderna vaccines are the first vaccines based on mRNA technology, and there is significant research that is required to evaluate the nature and the duration of the immunity they induce. And what we also have to understand is that data on AstraZeneca and Sputnik vaccines is minimal at best, and the current data is insufficient to make an analysis out of. ICMR is sitting on a huge amount of data, but they have not yet published any articles into the journals. But end of the day, the clinical observation point to fact that all the vaccines, if not equally effective, are at least getting the job done. And I had gone through an article which was like a serology of immunology of SARS-CoV vaccine. This was an article which was published in 2020 December. By the Department of Pathology, Microbiology and Immunology at Stanford Medical School. It was a very interesting article because it showed many things. And there were many shockers in this article. The first thing is that when related to COVID, the half-life of the antibodies was found to be 36 days, and they found that it plateaus around 70 days. Later on, there were no detectable antibodies after 277 days. And another shocker is that at 8 weeks period, the median reduction of the antibodies was found to be more than 70% in the both symptomatic as well as the asymptomatic group. So this is what we have not expected. We expected that the vaccine effectiveness and the duration will be large. However, when we look at other vaccines, something like measles is supposed to last for a lifetime. And though the mechanisms are live attenuated, the live attenuated vaccines, however, have been shown to last for a longer duration compared to this mRNA vaccines. And because the mRNA vaccines are relatively very new, we don't know how they will stand the test of time. And this was what I wanted to publish. I wanted to show this article because I would be again asked for the evidence. I wanted to read this sentence. The individual, although there is some evidence for aberrant activation of T cells in severe disease, as stated above, antigen-specific cells could be detected in COVID-19 patients, and both arms of cellular immunity can contribute to an antiviral response. However, interestingly, they also found that while the neutralizing antibody titers were not associated, where higher neutralizing titers were also not associated with the decreased severity of the disease, and antigen-specific CD4 cells responses were. So, good vaccine, good antibody titer does not directly mean a mild disease. So, when we come to the daily cases in Israel, back from the initial graph, this is the first graph what we have seen. First wave followed by a second wave. They started vaccination at this point of time, and then they continued. They have found the cases come to near nil and coming to double-digit cases per new days, and almost no deaths for a few weeks. Later on, when the elections were done and the new government was sworn in place, and there was a lot of movement about and lockdowns were restricted, what they found was that at this point of time, the green point of time is the point where they initiated the booster dose. Despite the booster doses, the number of new cases had increased significantly. However, this data is incomplete because though the number of cases had increased significantly, the hospitalizations and the death had come down significantly. So this suggests that vaccines effectiveness, as well as the duration of effectiveness, as well as the booster doses are definitely in our play, and we should consider them at least for the high risk population, and we should justify basing on the population as well as the geography. Thank you, sir.
Thank you, Naresh. Thank you, Dr. Misra, for initiating and moderating the session. We have Dr. M.V. Rao, has already been pointed out, who has been a vast experience in managing these cases. Sir, we have been listening these queries. I think you have been also in the forefront, getting the calls, whether should I get another dose? What should I do? My antibodies levels are very low. As Misra pointed out, it's not from the just general population, but also from our medical fraternity. There are many queries in and around. So I think in India, the initial vaccination started somewhere in January. The second dose was somewhere in February for at least healthcare workers, both public and private, if I remember correctly. So most of our population got only these two vaccines in the initial part. Those are Covishield and then followed by Covaxin. So what do you think, sir? These vaccines, we received 2 doses, and which we consider as a primer in the initial part. How many days these vaccines going to help us or act as a protective mechanism? And some of our colleagues and even some of our patients with a lot of enthusiasm are also getting tested with antibodies. And whenever they have a very high antibody, they were very happy. And some of them get calls very disappointedly that my antibodies were low and all that. So what do you think, sir? How many days or months or years these vaccines are going to protect us? And what is the role of actually evaluating the effectiveness of vaccine by doing an antibody?
Good evening all, Dr. Ramana, Mishra and Dr. Naresh Chandra. Naresh, that was an excellent review of literature, nice presentation. So probably have cleared, I hope you have cleared all doubts of many of the listeners. So the burning question by almost every colleague and patients is when to take booster, is it required or not? And as Naresh was telling, so this is a new field, both mRNA vaccines and the vaccine which was developed within less than a year started being given without probably post-marketing surveillance, and probably because of the demand and because of requirement, we have pushed almost all the countries and the research organization pushed the vaccine to the market and for the public purpose. So it's a very important public health movement in the world, and we've been seeing a lot of benefits of vaccine and also some myths. And the most important thing is whether the vaccines are helping or not. Definitely they're helping. We have been seeing patients who have been vaccinated are getting infected, but they are not getting hospitalized. One. Number two, even if they're getting hospitalized, they're not dying. I have lost only one patient who was fully vaccinated. And second thing is, as Dr. Ramana says, that we get, all of us, even I got the antibodies a number of times. And when we see our antibodies response, when they are good, we feel very happy. In fact, our colleagues discuss that my antibody is this much, they feel proud. But antibody titer, the value doesn't really indicate the proper immunity. We have a patient whose antibodies are around 250, but he's now on a ventilator. So the good titer of antibody doesn't mean that you are completely immune to the infections. You get infected, but very rarely probably go into severe disease. So we got to be very careful because we are all frontline workers, work very close with the patient. So don't have that false security. I've been seeing my colleagues not wearing masks in the COVID ward. I've been seeing my colleagues who are not taking proper protection. Of course, we all forgot PPEs now. They're not wearing face shield, all those things. So I request my colleagues to, all of you, be very careful. Of course, all of us taking vaccine. And according to Naresh discussion, now probably our immunity is weaning off because almost 6 months that all of us have taken vaccine. So we are the first people to take vaccines, so frontline workers. And if unfortunately the immunity goes up, we are the people who are going to get infected again the second or third wave. So be careful. This is a month, October, November, where our immunity is going down. And don't be in a false security. Don't feel that you have good immunity by checking your antibodies, though there is a cell immunity, but we should be careful. Third is whether to take booster dose or not. So that's what probably today's burning question, and all of my colleagues ask me every day. So I have a chance to visit US. So the paper from Europe came at the time that the mix of vaccine, AstraZeneca followed by the Pfizer vaccine, is really good. Then I took the approach, took one vaccine, and the antibody titer they checked out of the interest, it was almost gone up more than 1,000. So at least theoretically, that shows that there is a good antibody response with the booster dose. But in our country, as Naresh told, it's not the time to think about the booster doses because sadly, majority of people are not vaccinated fully. So first, our aim is to immunize everyone. Then only we can prevent the new variants. Then only we can prevent the burden on hospitals. Then only we can prevent so-called third wave. So to summarize, don't depend upon the antibody test and don't feel secure that your antibodies are good. And most important, don't forget the basic principle of your protection. Mask, hand wash, face shield, PPE if required, and don't work out. I'm already seeing we're all joining parties and attending marriages and workouting. So try to avoid them as much as possible.
Thank you, sir. With that wisdom, as we all understand at this point of time, we may not have a definite answer how many days, how many months, or how many years this vaccine is going to protect us or prevent us. But with our previous experiences with other influenza vaccines or in the same form of other vaccines, we expect, or some of these manufacturers expected, that this vaccine may be effective at least for 6 months to a year before we actually come across further new cases, new infections, and this vaccine escape during this period. So, and as rightly pointed out, sir, the antibodies may be one way of adaptive mechanism, but we may have a cell-mediated T and B cell memories, which may also give us a protection for a longer period of time. So just because you don't have antibodies, that may not maybe make you panic that you may need a further doses of vaccines. So as you rightly pointed out, at this point of time, we were the initial people who got these vaccines. And now it is getting slowly waning off, or maybe a time where we may need to look at that immune waning. You had actually seen the first wave, and then we had actually vaccination to the healthcare professionals, then elderly population. And then we saw a huge second wave, and followed by the second wave, we also see a staggering of cases in and around, with at least every hospital, or at least 5 to 10% cases are still floating in and around. So what was your experience after vaccination? Maybe some of them are partially, some of them are full vaccinated. we only had two vaccines in India. One is Covishield and the other one is Covaxin. What was your experience of patients who actually the manufacturers claim that, or the studies claim that at least they will have 100% protection to severity of the disease and hospitalization, even though they may not have 100% protection to infection or a symptomatic patient, but it may have 100% protection to hospitalization or at least the severe disease. So what was your experience during this last post-vaccination periods?
If you see, then the good observed study is that the vaccination in our 3 hospitals, particularly Somajigoda, we vaccinated about 1,050 healthcare workers. And during once we fully vaccinated them, we had only 5 to 6 patients, healthcare workers who got infected, and only one of them got admitted and he got discharged after treatment. So he never had any problem. He didn't require any oxygen. He required oxygen, about 2 liters per minute for a day or 2. Looking at that, this observation study says that vaccine has definitely helped us preventing serious disease, hospitalizations, and deaths. So by preventing hospitalizations, the burden on the hospitals come down. And definitely there were infections. Patients, doctors and nurses became positive. They got mild infections, like very, very mild symptoms, and recovered by simple home isolation. So that shows that vaccines definitely help in preventing hospitalization, serious illness, and death. Deaths are almost not seen. Only one of my patients died after fully getting vaccinated. And unfortunately, of course, though not reliable, the antibiotics were not really significant in the patients. So definitely vaccination, fully vaccinated people are definitely protected for at least initial 6 months. So now the question is that after 6 months, now we have completed 6 months almost. Now we do not know exactly how these vaccines, AstraZeneca and Covaxin, are going to last. I mean, the immunity is going to last. So what all we have information as the data is from only US and Israel and other European countries where they use mRNA vaccines. So we have to be a little careful because now, according to most of the papers, the immunity is waning off in 6 months. So we got to be careful. So far, so good. And now we have to wait and see. And my suggestion is that suppose if the infections are going up in our country, because healthcare workers are very scarce in our countries, I think all of us should get vaccinated with 3rd dose if the resources permit.
So as rightly said, sir, I think the same experience was expressed across the globe and even in India and even in many parts of Hyderabad, sir. What we have seen some of these immune escapes, some of these cases trickling down after reinfection, after vaccination, but the number was extremely low. And we can very clearly see that the majority of the sicker patients were non-vaccinated patients who were coming or a partially vaccinated patients. And as you rightly pointed out, very few of them landed up into the ventilator and death. So we do understand it. No vaccine can be 100%, as you rightly mentioned with your wisdom, that we need to continue our protection as before without actually putting down our guards. Sir, now that we have gone through the initial 2 vaccines, the first initial vaccine followed by a month's vaccine. So now we are talking about booster dose. And what exactly is mean by this booster dose? And do you think putting behind how many of our Indian population got vaccinated and where do we stand? Do we have any sufficient stock or not? Do you really think now we have evidence which is piling up favoring probably we may need a booster dose in the future?
Yeah, there are 2 points. One is the individual perspective. Second is the public health perspective. See, looking at our country, a large population of 1.4 billion, and most of the people are not yet vaccinated. According to Naresh, less than 50% got vaccinated. So most of them are vaccinated with 1 dose. So still we have a long way to go to vaccinate all the people. Till that time, I think it's not really justified to go for 3rd dose because our resources are limited. So scarce availability of the vaccines, I think first our aim should be to cover all the people, particularly people above 65, vulnerable groups, and everyone should be given vaccine first, that is 2 doses. Then only we can think of booster dose. But if there is a 3rd wave, because all of us are now finishing 6 months of vaccination, fully vaccinated course, if the cases start coming up in the healthcare facilities, to protect them, to preserve the resources of particular healthcare facilities, I think the government should think of giving booster dose at least to the healthcare workers. And of course, if the government boosts the production of vaccine, they can also, like US and Israel and other countries in Europe, they can start giving booster dose, but it's a long way to go. I don't think it's feasible or possible in our country. So first, let us finish the 2 doses in all the vulnerable population.
So Naresh, what do you think? What is the booster dose? What were the initial 1 or 2 dose? What are those? You in your presentation you showed after the first dose, you get your antibodies high, then you get it down, then you give another dose in a month. And what do exactly the booster dose you mean?
So the booster dose is any dose even subsequent to the initial doses recommended by the manufacturer. It is anticipated the waning immunity, in anticipation of the waning immunity, to just to push the immunity and just to keep the titers up, as we understand right now. That is the role of the booster vaccine as of now. But we also seem to understand now that it's not just the titers of the antibodies, it's also the memory T cells as well as the memory B cells, which also have a good role to play. And coming to the newer evaluation for the CD cells as well, sir. Cytokine ICS assay and ELISpot assays are available, though not available to the general public. These 2 tests are available to identify the T cell mediated responses. However, is it widely available to the general population and all, and to assess the efficacy of the booster dose? We may have to rethink the assessing of the antibody titers, and we have to move away from the assessing the antibody titers.
Dr. Misra, can you switch on your camera? Dr. Misra, are you around? See, Dr. Misra, there are a question from somebody who says that one of our patient who is a diabetic hypertensive completed our 2 doses of Covishield, came to the hospital with severe illness and succumbed. So what was your experience? What was the trend you saw? How many of your patients after vaccination did get succumbed, and how many of them were milder diseases and not vaccinated?
I believe what like Ambirao sir was telling, most of the cases who got admitted was partially vaccinated. I think one person who got severely ill, if I am not wrong, he received Covaxin.
Exactly, yeah.
So we have not seen a single case who was after getting both the vaccine of Covishield, got seriously ill and went into ventilator and all. There are few cases got admitted even after 2 doses of Covishield, but they were not very serious. A few people required like 10-15 liters of oxygen and all, but they came out. That was the maximum what happened. But I believe 2 or 3 cases where after the full vaccination of Covaxin, they become sick enough to requiring NIV, and one person went into ventilator. I think that only one person was, I believe, expired, if I am not wrong, but that patient was vaccinated with Covaxin only. I am not very sure, or there is no clear-cut data that Covishield scores over Covaxin, but that is what our experience is with whatever we have seen after the double doses of vaccines.
Even initial data of ICMR says that Covishield scores little over the Covaxin one. Secondly, the problem in the country is that they have increased the gap between 2 doses actually. So probably that's because of the scarcity of the vaccine doses. But I think the ideal interval should have been, I think, 28 days and if necessary, booster dose. But even AstraZeneca followed same thing in some other countries. But as you said, Dr. Misra told, I think the reinfections are infections again, and also see that these are very uncommon in people who have taken Covishield. So somehow we are seeing more patients, more from the Covaxin group than we are seeing in symptomatic patients actually. So
what is ICMR data, Naresh? What was the percentage of hospitalization post-vaccination, first dose, 2 doses?
Sir, ICMR has not published any articles as such. I was not able to get any articles. The only data I got from ICMR was through the press.
Yeah.
The reliability, I'm not very sure of it, sir.
You are correct, Naresh. One ICMR says that the infection rate, the admission rate was 0.03% with the Covishield and 0.04% with Covaxin, but they have not published any in the journal. It's only a press meeting Dr. Bhargava told us.
So to answer that question which the audience raised is, we all saw the cases after the vaccination also coming to us, getting a few of them getting sicker and probably getting ventilator. I think there can be a mere overlap of coincidence where few of them were Covaxin post-vaccinated, few of them may be Covishield post-vaccinated. There may be a variability of observations, but yes, we did see, and even whatever number, 0.00, 0.04%, 0.03%, there is still a chance that among crores of population, when you get vaccinated, few of them do trickle down to hospitalization, and there may be also some mortalities in them. So like any other previous vaccines, Covishield, Covaxin, or any Sputnik which are available right now are 100% protective for even hospitalization, even for deaths. That's what has been our experience. There are on and off cases trickling down to our hospitals who lost life after a fully vaccinated. But in the same point, we wanted to also emphasize that after the vaccination, particularly when we looked at our hospital staff getting fully vaccinated, the first wave admissions were completely much higher than what we have seen in second wave. And the number of ventilated cases, number of deaths has significantly been much lower. So that's what has been information across the globe, not only just India. So we hope that those are because of the vaccine related. Sir, you raised a point. Right now, our good amount of population is not vaccinated. Probably we need to look at vaccinating all our population at the community level first. That should be our first priority at this point of time as a country, as a healthcare system. But if at all we come to a stage where we have completed our first dose or a first roll of vaccination, the first 1 and 2, then if at all we come to a stage where we need to give a booster dose, and then who you think are the first initial high risk groups who said get vaccinated, Dr. M. V. Rao?
Yeah, Dr. Raman, I think the first group, of course, I'm selfish, doctors and other healthcare workers, because in a country like India where the healthcare facilities are really less, so we have to protect that department. So first due to them. Second is the people above 60 years. Abroad is above 65, but ICMR says above 60 is the age where our people's immunity comes down. So better to give in people above 60 and all the persons above 18 years who are having other debilitating conditions like organ transplant patients, diabetics, and cardiac and pulmonary disease patients. So those, like what we are given in the initial vaccination program. So all these groups should be covered. So, but I think, as I told earlier, it may take some more time for us to get all these booster doses because now we have not yet completed. So healthcare workers, other frontline workers like municipal workers and police personnel, and people with multiple medical conditions, immunocompromised states, these are the groups to be covered initially.
So rightly pointed out, sir, we have also some information across the mRNA related vaccines where they have seen the waning of the immunity or whatever the antibody titers has been seen significantly in elderly population more than 65 years, and also in immune suppressed patients who are on immune suppressants. So those are the two categories of patients, as you rightly pointed out, elderly and those who are adults but within 65 years but having some immunosuppressant. So the immune build and the immune continuity has been hampered even in the information. But again, healthcare workers, as you rightly pointed out, the concerns which were raised by CDC, even FDA, and even WHO, that healthcare workers may come across exposure to these multiple variants in different times. So whether you say a Delta variant, Delta plus variant, or these variants may also sometimes play a role to escape your immunity. So that also makes this population or this particular subgroup of population healthcare workers may be highly prone to that. Dr. Naresh, can you throw light on these three categories? Was there any information right now from your different studies where you have elderly, more than 65, immunosuppressed, and healthcare workers?
Sir, I have not gone through these articles, sir. I've concentrated on the booster dose. I'll just
find booster dose. I'm talking about booster dose, where actually they found that after the second dose, when they followed the different age groups, and
yes, sir,
followed elderly age group had a early waning.
Yes, sir. The Israeli study, actually, they have followed up the same group, but what they did is they had followed them only for 12 days. They have not followed them up later. So we are anticipating a new article where they'll follow up the same population for the next 3 to 4 months and they'll publish that. Maybe that will throw a good light over that, because they were the first country to start this third dose booster vaccination in the elderly population.
Okay. So, sir, what do you think? Whether we should get the same vaccine? Suppose I think we had two vaccines in the early part. So few of us got Covishield in the initial part. Later on, few had a lot of favorism to Covaxin. So many of our healthcare clinicians or other general population got these only early vaccines. So now recently, I think in the last 4 months, we are having Sputnik also. So what do you think the second vaccine should be? I still believe that many of our clinicians also started jumbling and using as a boosters. But what do you think at this point of time? Should I actually use the same vaccine as a booster, if at all I'll get a chance, or if I believe my immunity is waning, or should I mix and match?
Unfortunately, the studies about this are not available. One is about efficacy, second is safety. See, we have two vaccines initially, now we have third vaccine. So we have Covaxin and Covishield. So far, we haven't any study in Indian population mixing these two vaccines. Of course, there were some accidental inoculations in one state, but we don't know about the results of those patients. But if you look at abroad, and particularly in Scandinavian countries, initially there was a concern about the side effects of the AstraZeneca vaccine. So first dose they stopped. The second dose they gave an mRNA vaccine, that is Pfizer-BioNTech. So they found surprisingly better response than giving 2 doses of the AstraZeneca vaccine. So that's how this came up, and Belgium, other countries started mixing up these 2 doses. And I told you earlier, I did same thing. I mixed up. I took 2 doses of the this thing, and when I went to US, I took the Pfizer vaccine. Response was good, at least by antibody titer. But coming to India, WHO says that if at all you booster, use same product, don't mix. So far, we don't have a safety data, because safety is more important than efficacy initially. So at the moment, we should not mix the doses. But there is evidence in other countries that mixing of doses gives better response, better immunogenicity, so better efficacy.
So probably we may need to wait to see if we can get some data related to those who actually initially got Covishield. Getting a second dose vaccine gives any better benefit, like what we have seen with post of Covishield mRNA vaccine gave. But as you rightly pointed, we don't have any strong evidence in support or against that. So at this point of time, we may not have a clarity on that. Probably in future, we may have further information related to that. But at this point of time, if at all we consider a vaccine, probably the vaccine will be the same group at this point of time.
Actually, ICMR should encourage they should go for some studies about mixing, and we also should probably take it up and probably publish. I think this is right time.
So what do you think is the ideal duration, sir? Suppose if at all we try to get a booster. Now we are, as you said, 8 months down the line from the second dose. If we consider the last part of February, I think most of us got vaccinated. So, and other elderly population also got in the same time around in the March, April.
Yeah.
So right now we are at around 6 to 8 months of the time period. So where do you look at is the ideal time to actually get into the booster dose?
If you look at the literature, US CDC and also European says that 6 months is the ideal time. Even Naresh explained us that by 277 days, all the immunity disappears. So it's ideal to take a booster vaccine at the end of the 6 months of the second dose. So when you fully vaccinated, from there you take 6 months to take the booster dose. So that is the usual this thing. We have to wait and see. I think 6 months is the ideal time. So now probably if at all we take vaccine, we should take now. Most of us finish 6 months now.
So there was some out of context data. Do you have any experience of particular blood groups? We have seen there were reports B positive and all that getting more infected, more sicker. Any information related to that?
I really did not concentrate on blood groups, because though they say that particular blood group is having immunity for the more infected. I think Dr. Mishra, can you explain this? Can you add on something on this?
I don't think we have seen any prevalence of one blood group having severe infection or few blood group are escaping the infections. We have seen initially, I think O positive was the thing they told, that O positive people and B positive people have a lesser infection compared to others. But we didn't find any significant changes in the severity of infection as per the blood group, at least in the first and second wave. We were, I think after the first wave, this thing came up. During second wave, we tried to see in our cases, is there any difference? But there is nothing significant, at least.
There's
per
one
the
question
blood
from one of the participants. Is there any increase in incidence of thrombotic events after booster dose? I think Naresh should probably explain one of
Yes,
the even I
Dr. Naresh.
articles. There's no increased incidence because whatever side effects that the adverse effects you've seen, local reactions in general, the incidence is same. It's not increased in the booster dose, so it's safe at least to, in the Pfizer and Moderna vaccines. Yeah.
Naresh,
Yes, sir.
any comments on that?
Yes, sir. Actually, it was something like a bad PR for Oxford AstraZeneca, because later on they released a press statement stating that the amount of thrombotic complications was the same in the unvaccinated group as well as in the people who received the vaccine. So it was something less like a bad PR rather than having any scientific basis for that.
But right now also in the third booster dose, the mRNA related information, it was more related to mRNA vaccines across the globe. In that also they found there is no much significant increase in incidence of complications or adverse effect. In fact, the adverse effect were much less compared to the earlier doses. So that actually clears the safety profile of it. So the incidence, we also expect that the thrombotic complications, whatever happened during the Covishield related period, and there was also terms related to the thrombotic episodes or the thrombocytopenia post-COVID vaccine, Covishield vaccination. But I think at this point of time, the information is more from mRNA, but that information says the adverse effects or complications or reactions all are comparatively much less than those initial two. Yeah. There is a comment from Dr. Mona Lisa saying that a small group of individuals by ICMR showed that there is a better antibody response when they had actually mix and match. But again, as usual, they have not published data anywhere, and it was just a press release. So we have to take that with a pinch of salt till we get any solid information. But maybe that's a encouraging point where we may need to consider a study on it, as pointed out by M.B. Rao sir. So there is again, what is your experience on a high dose of cocktail in severe COVID ICU patients? Mr. Any experience from that?
I don't think we have used high dose of cocktail. I think newer data are coming up even for prophylaxis in as an antibody cocktail where they have seen.
But that dose is much lower. That dose is much lower.
That normal dose where they have seen it is like staying in the blood for almost 3 months post antibody cocktail. But it's like we don't have that much of experience at this point of time as a prophylaxis.
I think David is trying to ask, this is the information which actually the trial recovery's subsequent trial, which after this initial prophylaxis or mild symptomatic patients, before they go into severity, there was another study which actually tried to see whether these higher doses in a patient who is already on a ventilator with hypoxemia has shown a marginal improvement in mortality benefit. But yes, our experience with a very few cases couldn't actually show much benefit in them. The prerequisites for that was they have to have an antibodies negative before you start, and that has to be within those 7 to 10 days period. And even in sicker group, they tried to use this higher dose and see, and they found a marginally mortality benefit in them. But the point is it's extremely expensive, and the data has there is no robust data on there. There are further trials which are going comparing intermediate doses also, not the 600 combination, not the 400. We still are waiting for that. Our experience was discouraging. Both of our patients whom we used couldn't make it. I think they were too late to use. There was a sicker group of patients where the family came up with the same suggestion information from others, so we tried them, but we couldn't save them all. So what do you think, sir? What will be the ideal time? Actually, should we think that we should be considering these vaccines, most booster vaccines?
I think if they're available, and I think we should take it 6 months after the second dose. So the booster should be taken as soon as possible, because we have seen in Israel, in fact, Pfizer has sponsored all vaccines program in Israel, all the population vaccinated, only on the agreement that they give all the data to them so that they can publish. So that's what exactly Israel has become a real experimental country. So where they have seen after getting fully vaccinated, still they could see the third wave. So I think better to have booster dose if it's available, at least for particular groups, specific group what we have mentioned earlier. But again, the point is that, say, public health importance, we still don't have adequate vaccines to give it to all the public. So then the government has to probably jump. And second thing is that now there is a new thing. What they are thinking is about fractioning the doses. Like rabies, initially they used to be 1 ml intramuscular, then they make a 0.1 intradermal, so that one dose can be given to 10 patients, 10 individuals. Similarly, now they want to fractionalize the COVID vaccine. So the trials are going on now. So, for example, we are giving 0.5 ml now. Suppose if they give 0.1 ml, one dose can be given to 5 individuals. So that's how we can give it to more and more patients. So that's still going on. WHO is encouraging those trials. If they prove to be effective, I think present dose of vaccine will be sufficient for our population.
There is another question, sir. Do you see any relevance in monitoring or following the levels of antibodies on deciding before any booster doses?
At the moment, most of the papers say no. You cannot depend upon the antibody level, whether to take a booster dose or whether to probably think that you are not safe. So, because apart from the antibodies, the first antibodies, whether they are lazy antibodies or proper neutralizing antibodies, we don't know, one. Number two is that there is other cell-mediated immunity where the memory cells are there. So we don't exactly know their role at the moment, but we have seen patients who are in very less number of antibodies still are protected, and we have seen vice versa. People having good antibodies still have infection. So it's very difficult to comment that because there is no clear-cut data on these. So still we have to wait and see.
Very interesting question and very commonly encountered. The question that even after vaccination, we see patients coming with HRCT findings of COVID with symptoms, but RT-PCR seems to be negative. Do you have any guidelines to follow these patients, and please suggest ideal time to give a booster dose? Yeah, this has been a very common question. Many attenders and families asked us. We went for a vaccine and these symptoms and CT changes happened within a week or 10 days. So this is induced by vaccine. This was very common in second wave particularly. So because that in the same time, the vaccine drive was also going on in very heavily and there was a lot of crowd everywhere.
Exactly.
The first thing is no vaccines can induce a COVID disease. That
Yes.
We have to first understand. COVID vaccines can induce some anaphylaxis, some allergies, some kind of thrombotic phenomenon, some kind of fever, myalgia, rash, GI symptoms and all, but they cannot mimic a disease or cause COVID. So they are all live attenuated or mRNA or a particle vaccines like spike protein induced vaccines. So they cannot cause a disease. What happened in many of these situations is when they got to these vaccine centers, there were clusters. And with some wrong reason, the second wave, the variant, which is variant of concerns, was highly infectious, and it just infected all those population at a time in the same place. So that made these all patients coming positive. RT-PCR negative, yes, there were some situations where we understand RT-PCR have its sensitivity and specificity, and the duration, timing, sampling, there can be many things. But if I have a patient whose CT findings are probably CORAD 5 and suggesting symptoms with an exposure, I will treat like a COVID infection, and probably that infection site is vaccine site. And the guidelines to follow is, see, first of all, we have to clear this doubt in the minds of the patients and family. So we don't have any guidelines to actually see, to ask them to go for a CT test or any saturation follow-up following a COVID vaccine, either a Covishield or a Covaxin. We just tell them to monitor if they have any symptoms like fever, myalgia, or any new symptoms which actually disturbs them. We ask them to come back to the healthcare centers. We had few cases of allergy, anaphylaxis. We had very few cases of high-grade fevers, myalgias. Some of them also had a GI symptoms. So these were different kind of symptoms, but not in the ideal. The ideal time to suggest a booster dose, we may not have a perfect answer to that, but at this point of time, with existing data across the globe, somewhere as pointed out by MB Rao sir, maybe somewhere between 6 to 1 year. So we are just waiting for that further information. So we are seeing such presentation after 6 to 8 months after vaccination. So this is again another question. For example, the same thing which has not happened after immediate vaccination, but that may happen after 6 to 8 months of vaccination. Is there any possibility that these patients may get infected or reinfected.
Probably, yeah. Probably there's a new infection, probably under
So,
variant of concern, yeah.
Yeah, Dr. Sumalata, that's what we were talking about. If you see in the last month, the WHO has given a statement, interim analysis report on booster dose. CDC is talking about it. FDA has given some approvals. So the whole world is talking about, and Israel being a very small populated country, they have actually given 100% vaccination to all their population, first and second dose. Followed that, they have seen a rise in cases, and they have seen the above 65 years are the earlier age group to get this infection. So they have started to get a booster dose. If you actually come across even Joe Biden from the United States of America's president also got a booster dose recently. So this news is across the globe, and everybody is probably following this booster dose related thing. So what I probably put across is after 6 to 8 months, there is likely possibility. We may not have a concrete standard evidence at this point of time. There is a likely possibility that you may have a immune waning. So when these immune waning happens, though, there is a likely possibility that if you get a new variant, you may have a risk of getting infected, and that may be happening right now. As you said, 8 months down the line, you may have a scope of or a chance of getting infected. In any comments, Naresh, you have been gone through so many other reviews of literature on this.
So, sir, I had one very interesting finding. I've not been aware of. So when they saw natural immunity to the other viruses, and this was something that was unbelievable. The half-life of vaccine of immunity for other viruses. For varicella zoster, the half-life was 50 years. And for vaccinia, the half-life was mentioned as 92 years. And more surprisingly, mumps, the half-life was mentioned as 542 years. And for measles, it was mentioned 3000 years.
That's a live viruses, yeah.
Yes, sir.
And
what I am looking at is that all these viruses, most of the vaccines we have are live attenuated. No. So probably
I'm not sure. Maybe we are also I think there is a lot of work going on in the nasal drops of this live attenuated vaccine. If, as you pointed out, if we get a live attenuated vaccine or a live nasal drop vaccines in the future, that may give us a longer protection or some of those things. So there was another question right now on the desk. So in the recent times, we have seen some influenza rise. We have seen also a dengue rise. So not just COVID, but we have seen other viral diseases going up. Some of our cases were CT scan showing patchy consolidations and influenza A being positive. Some of them were H1N1 also positive. So that was the situation. So not all cases at this point of time are just COVID. So what was your experience with that, sir? Other than COVID, other viral infections in the recent season?
Actually, if you look at the last year's our hospitalizations, almost we hardly saw any patient of dengue or malaria or diarrhea or hepatitis. So probably that was because of the behavior public. Everyone got scared and they were very careful, hand hygiene, mask, and they were not going out and probably staying at home and probably keeping their home clean. So that's probably the reason that we didn't have no viral diseases actually, no dengue, no influenza, no hepatitis A, B, no typhoid. So in fact, except COVID, we have not seen any patient in the hospital. But as people getting relaxed and coming out, there are a lot of gatherings and people are flagging their hygiene. Now we have seen a lot of dengue patients this year. We are seeing subtypes now. We have seen some amounts of diarrhea and typhoid. So all are coming slowly, though not to the great extent, but definitely there is definitely these cases slowly coming up. Probably another 1 or 2 years again, we get the same epidemics in the monsoon season. So monsoon diseases were very less last year, and they are almost more than 50% of the usual incidents this year. And by next year, I think people forget about all these precautions. I think we as usual again.
I believe we have 2 cases, sir, actually. One case, I think 2-3 cases where we got H1N1 positive, and 2 cases where influenza A were positive.
Yeah, exactly. Yeah.
And they were sick actually. 2 of them were on ventilator, and we have to prone for several times in influenza case. almost 8 or 10 times, but still the patient was not improving significantly.
Yeah.
The last year we didn't see much, but this year again there are few cases cropped up. As sir was saying, lot of scrub typhus and dengue cases came this year, which were not there last year. I want to ask one or two questions actually. What Dr. Naresh told, let's see what we are thinking about live attenuated vaccine is, let's see passive vaccination. Now active immunization is going on. A lot of people are getting infected itself. That is active immunization.
Yes.
So they are all live vaccines. You can say it to be live vaccines.
Sir,
And a
probably
lot of
that's why
people,
we may
even
not
if,
be.
yeah, even after they got infected in the first wave, the few cases got admitted again in the second wave. So I don't know, like what is the
very interesting comment, Dr. Misra. See, what is expected out of a natural infection, which you wanted to comment, is generally the trend what we see in natural infection in any influenza, the reinfection rate, the reinfection chances generally will be a year or two till you have a antigen shift or drift or a new variant comes. It doesn't happen within the same season or within the year. But unfortunately, the COVID is behaving differently. It's not true for COVID. The concept or theory of herd immunity, the concept of theory of getting reinfected in COVID is completely varied from the other viral experiences. So what experts are saying, the COVID reinfection is quite possible within the same year, within maybe 6 months to 8 months. So that's a common pattern or a phenomenon which has been seen across. So the herd immunity or the live natural infection related immunity is not always a option or a possibility, as you said. And particularly we expect, see the comment, if you see what about vaccination after infection, that is again happening now. Somebody got a very serious or a severe COVID. What is our call for vaccine? We ask them to get vaccinated. The reason is we say the natural infection immunity or a T cell memory, even we say those who are actually mild symptoms or no symptoms, their immunity duration may be much lower than those who had actually severe, hospitalized, had a severe disease. But in spite of that, they say once your disease is over, you give a gap of 3 months, you need to get vaccinated with the 2 doses. The reason for that is over a natural immunity, we assume that the vaccine will have a better effectiveness because of its specificity or the immune boosting system. So that concept theoretically, which you are asking, natural infection should give us a 100% live attenuated kind of things is not working in COVID. And as he pointed out, if you see varicella, the chicken pox or the varicella, that's if you get infected in your childhood, ideally you should be getting a lifelong immunity. We ask, say, you say chicken pox party or something like that, where actually you allow your kids to get exposed and get an early disease, then not getting this disease in your adulthood. But yes, there are some escapes. A few of our adults where we come across rarely they get a serious second infection. And vaccines also, once you get vaccinated, it is lifelong. You don't need to any further vaccinations in chicken pox. But every virus probably is varying their way of presentation. And again, antibodies also. See, if you look at the data related to the antibodies, the information is the antibodies which you are now looking at spike protein may not be the only modality with which your vaccine is protecting you. We actually at this point of time don't know how do we actually assess the efficacy of a vaccine. There is no standard guidelines or information that how to monitor the efficacy of a vaccine. The antibodies which we are actually now looking at can only give you is whether there is an active infection or this patient got a infection a few days back. That's it. Those probably antibodies will give those information. Exactly. But titrating whether these antibodies give you a efficacy of your vaccine is questioned. There is definitely a question. So we cannot actually rely on those things. There is again another point or question raised. The scrub is negative, malaria is negative, influenza is negative, and COVID is negative. Few of our cases came with MODS and succumbed. Are you encountering these kind of cases in your hospital? Any comments, sir? Ambira, sir, any experiences with recent?
In fact, most of the patients where everything is negative, scrub is coming positive. I think Dr. Mishra has seen few patients recently. But there are some more viruses where we don't have diagnostic modalities, particularly hantavirus. In fact, CMC Vellore says about 13% patients with CKD have the IgG hunter antibody. So it's a very common infection in the country, but unfortunately, we don't have diagnostic facilities so in most of the hospitals. So hantavirus is one thing you should think of. And there are so many other viruses, flaviviruses, of course, though, of course, some other viruses which cause polyarthritis like Ross virus, Nyang'Nyang virus. So they don't cause systemic disease, but we should think of other viruses, particularly we didn't see, but there were some case reports in Crimean hemorrhagic fever, Congo, all those fevers in Gujarat a few years ago. Whenever we get a disease which we don't really understand, we should take the help of the NIV, Pune, or CDC of Delhi, and ask them to investigate for the other viruses which we see other parts of the world, particularly African continent. Because nowadays, you see, fortunately, unfortunately, because of COVID, there is no much journeys between countries. But during normal time, we see a lot of people traveling to all the continents, particularly from Africa, where we have a lot of these viruses. So whenever we find a case which is not diagnosed by doing all these tests, we should definitely take the help of the reference lab, particularly NIV. They usually come and take the samples and investigate further.
Yeah, it's true, sir. We may not be able to screen all the viruses, and there may be many unknown viruses to many of us yet. So at this point of time, I think we only look at the tropical fevers with dengue, lepto, malaria, scrub. And what we have realized is few of these cases where one of the outside report is negative, when we repeated them, particularly the dengue cases, when they come in very sick and hemorrhagic shock with capillary leak and multi-organ failures, they just don't make it within a day. As you rightly pointed out, there may be one report which is negative. Some of them may have a false negative. And leptospira cases, what we realized is some of these cases which are negative in the initial week,
exactly,
they turn to be positive when we repeat in the second week. But yes, there may be a possibility that few of the viruses we may be escaping. So, sir, what a wonderful discussion with not just the knowledge, but the wisdom of Dr. M.B. Rao, sir, which we all been following and we are proud of. And what a wonderful narration in such a quick time, Dr. Naresh, you have been given. So whenever we talk about this topic, many feel lost. When I inquired about this topic, many feel lost, no evidence, no data, no literature. Where do we get all this? But Dr. Naresh just took few minutes to say, yes, I will do it. I will get gather. And he put across a good show and trying to put across the all evidences at this point of time. And thank you, Dr. Misra, to come to this rescue of just initiating and bringing this topic and discussion. And I probably summarize the whole discussion in a way that we are in a period which is somewhere between 6 to 8 months post our second dose of our initial vaccination, that is Covishield and Covaxin. There is a likely possibility that we are in a period where they may be having our vaccine waning time. And there is a possibility that we may have a possibly getting infected if we get a new variant. So we need to be careful to follow up. But at this point of time, with current situation, we need to first primary vaccination across the globe and across India should be our first priority. If at all we get a chance, the booster immunization should be considered to the high risk group, as exposure group, the healthcare professionals, as high risk group, those who are more than 60 or 65 years, and those who have a severe immunosuppression, where this waning off or waning of immunity happens very quickly. And at this point of time, we also feel that maybe somewhere between 6 to 8 months or a year is that period where a booster dose can be considered. And whether it is the same vaccine or a mix and match, we may have a pockets of information, but no concrete evidence at this point of time. And WHO suggests to continue the same series of vaccine for the booster dose till we get a further information. With this, I actually thank all the audience and participants for their active participation and their interaction. And I thank all the audience and moderators and speakers, and I conclude the session. Thank you, sir.
Thank you very much.
Thank you.
Thank you, sir.